We are discussing a very important topic on amenorrhea. A woman might walk into the OPD, she might have an ambiguous genitalia, she might have feminine features but with testes as gonads. We need to screen and we need to assess the patient from the moment the patient walks into the OPD. While I was searching through the literature, I got through a quote, a strange infirmity, Lady Macbeth's amenorrhea. This was an article with Shakespeare's Diaries by Jenny Joy Labelle, and she actually wanted amenorrhea as it was an infirmity or mental weakness. So let's open this Pandora's box of amenorrhea, and I will be discussing in detail the primary amenorrhea and rushing through secondary at few points. The objective of today's talks will be the journey, will be understanding the basics, the clinical approach to a girl who comes with a primary amenorrhea, few case snippets and different compartment-wise classification. So primary amenorrhea, if we see, it has an incidence of 0.1 to 0.3%. It is specifically defined as no menses by the age of 13 years in absence of secondary sexual characters, or no menses by 15 years of age in presence of secondary sexual characters. So previously it was the age group of 14 and 16. Spirov still mentions it as 14 and 16, but the latest edition of Berek and Novak, it gives us 13 and 15 years with absence or presence. If we understand what is secondary amenorrhea, it is in a woman who has never previously menstruated for cycle of at least 6 months amenorrhea. Previously menstruated and 6 months amenorrhea, or if it had been irregular cycles, then at least 3 previous cycle lengths, then we label her as having secondary amenorrhea. So focusing on primary amenorrhea, we should be understanding the HPO axis, not going into the detail. As we all are aware of, the environmental stimuli, they affect the CNS, which acts on the hypothalamus to release GnRH hormone, which acts on the anterior pituitary to release FSH and LH, which in turn secretes estrogen and progesterone from the ovaries, which acts on the uterus, and then the menstrual blood flow happens if the outflow tract is normal. So the causes of amenorrhea are classified on the same lines as the CNS disorders, which can be physiological delay if it is in hypothalamic involvement, pituitary tumors in cases of anterior pituitary, or there might be inactivating mutation in beta subunit. If we go on the other side of the spectrum in secondary amenorrhea, in hypothalamic, there can be anorexia nervosa or the sudden loss of weight, or bulimia nervosa. The other pituitary tumors which can have an effect once the patient has already achieved menarche. The ovarian causes might include ovarian dysgenesis, the enzyme deficiency, premature ovarian failure or insufficiency in either which case. Then the uterine causes can be Mullerian agenesis or the androgen insensitivity syndrome or the congenital aplasia, and the outflow tract abnormalities in cases of imperforate hymen or transverse vaginal septum. And also there are autoimmune causes as well, and the thyroid disorders. So the causes of amenorrhea, if we have to make it simple, we will go from below and up. We will be discussing the disorders of genital, outflow tract and uterus, followed by ovary, then the anterior pituitary and the hypothalamus or the central nervous system. We have to exclude one by one to reach to a particular diagnosis. So if a girl comes to us in an OPD with primary amenorrhea, a methodical, systematic approach to evaluation helps arrive us at the most plausible diagnosis itself. And amenorrhea speaks for itself. We need to have a detailed history, examination, and finite tests. It is not that infinite we have to write a whole of the battery of tests. There is specific tests. Sometimes even without testing, we can actually come to a diagnosis with history and examination itself. So if we go into the symptoms only, I'll just brush through this slide. If the girl comes with cyclical pelvic or lower abdominal pain with primary amenorrhea, she might be having an imperforate hymen. See, we have to screen. Suppose a girl comes at 12 years of age or 13 years of age with primary amenorrhea, with secondary sexual characters present and no symptoms other than the amenorrhea, we can actually wait for another 2 years, but we need to assess. Suppose a girl walks in with features of Turner syndrome, and we are not going to wait for another 2 years. We have to screen and address the issues there and then. If there is an onset of amenorrhea following a history of endometrial curettage or uterine surgery, it can be because of Asherman's. I have seen girls or women coming to the OPD. They have got all the tests done, but if we go into the detail of the history, there can be an underlying history of DNC in the past. So we have to look into the history in detail. Amenorrhea, asymptomatic with secondary sexual characters, can be because of MRKH, which is Mayer-Rokitansky-Koster syndrome, or androgen insensitivity syndrome. Symptoms of hyperandrogenism can be present in both PCOS in both the cases. Galactorrhea, we have to see. Always examine the breast of the patient. By exclusion, we come on to the hypothalamic and the pituitary disorders, and the progressive hirsutism or the increasing features of virilization can be an underlying situation in congenital adrenal hyperplasia or the tumors of the ovary or adrenal gland. We should all be aware of the Tanner staging. I will not be going into detail, but we have to look for the Tanner staging for the breast as well as for the pubic hair in all the women with primary amenorrhea. So coming on to our first case, a 14-year-old girl, worried mother, she did not attain her menarche. She has her secondary sexual characters present. We did an ultrasound which was normal. So what next? The answer is we just need to reassure her. Reassure the mother and the girl and ask her. She will wait for another an year and then we will see if she still doesn't get her periods. Another girl who comes to an OPD at 13 years of age with her mother has a cyclical abdominal and pelvic pain with a backache and defecation issues with difficulties in urination. There is no family history of delayed puberty. She was never involved in athletics, had been taking over-the-counter NSAIDs for pain relief for the past 4 to 5 months, and had normal pubertal development with normal breast and pubic hair tanners stage 4. She has a BMI of 24. This girl I actually came to meet 3 years back, and she had an bluish purple membrane, and it was diagnosed to be imperforate hymen. As you can see, there was a collection in the vagina and the uterus. So the treatment for this was the cruciate incision, and as you can see, this was the clotted blood which came out. We are not supposed to do suction in these cases, and this was the follow-up scan for that girl. She already was on the heavier side and had bilateral PCO, and she also had right hydrosalpinx. And we need to counsel these girls. They might have tendency of endometriosis in the later life, or hydrosalpinx or hematosalpinx or endometriosis. So we need to be watchful for that. Also, these things need to be differentiated from transverse vaginal septum, which is unlike, there will not be a bluish discoloration just at the hymen. There will be a transverse vaginal septum almost at 2/3 and 1/3 of the vagina. It can be a high septum or a low septum. So the treatment is we have to excise the septum and then form the canal. I'll share a very interesting anecdote. There's a patient who came to Lady Harding gynae casualty, and she was in acute pain. When she presented, she had a blind vagina, but there was a small opening through which the blood was coming. She was actually 14 weeks pregnant, and she was having incomplete inevitable abortion, and she was having a transverse vaginal septum with that single hole in between. I don't have a picture right now with me. And she never had any dyspareunia, discomfort, and she conceived with that. So we took her up in the OT. She was evacuated, and the vaginal canal was formed, and she was asymptomatic after that. So we need to differentiate between imperforate hymen and the transvaginal septum. There will be no obvious vaginal orifice. However, in transvaginal septum, there might be a normal vaginal orifice. The valsalva manoeuvre will cause a distension at the introitus in imperforate hymen. However, there will be no distension in cases of transvaginal septum. As discussed, we have already discussed the cruciate incision and the excision of septum in these cases. There can be cervical agenesis, vaginal agenesis along with, and so coming on to the third case, she was an 18-year-old unmarried girl who comes to you in OPD with complaints of inability to attain menarche. She has never been sexually active. She attained secondary sexual characters by 15 years of age. All the negative history was ruled out, like loss of appetite, exercise, any hearing loss, stress, dieting, anything. She had a mixed diet and no addiction. She was a second-born child, no family history which was positive. There was no significant family history too. Her elder sibling had attained menarche at 13 years. She had normal secondary sexual characters. Her thyroid was normal, and the systemic and examination was normal. However, when we examined a local examination, the vulva appeared normal, pubic hair were normal, per rectal uterus could not be palpated. A urine for pregnancy test was negative. We did an ultrasound, it showed uterus hypoplastic with normal ovaries and follicles. So what next? Clinically, if we look into the picture, the salient points in this case are the primary amenorrhea, the normal secondary sexual characters, a negative urine for pregnancy test, and not palpable uterus on per rectal examination, and also an hypoplastic uterus on scan. So clinically, if we see, our diagnosis points towards Mullerian agenesis, which can be either Mayer-Rokitansky-Kuster-Hauser syndrome or androgen insensitivity. But without any test, we can still differentiate it between the two, because in androgen insensitivity syndrome, there will be very scarce pubic hair, or there may be less pubic hair or no pubic hair. But in this case, the pubic hair was Tanner stage 4. So there's a flow chart which signifies if we have to evaluate the primary amenorrhea patient, we do a pelvic ultrasound in a woman who is having normal secondary sexual characters. If the uterus is present, rule out the outflow tract obstruction. If the uterus is absent, do a karyotype. It will be 46XX in Mullerian agenesis and 46XY in androgen insensitivity syndrome. If the uterus is present and the other outflow tract is ruled out, we do an ultrasound. If it is normal anatomy, we need to understand the FSH, LH, thyroid, and prolactin. Only these 4 tests are required after ruling out pregnancy, even if she is an adolescent. If the enzymes are low or normal, it can be a physiological delay or idiopathic. If FSH, LH are high, it can point out to premature ovarian failure or resistant ovary, or might be gonadal dysgenesis. They might be elevated even in cases of chronic anovulation or PCOS. TSH high or low can indicate hypo or hyperthyroidism, and an increased prolactin has to be evaluated depending upon the levels by an MRI or a CT scan. So coming back to MRKH syndrome, it can be associated with urological anomalies in 15 to 40% of the cases, and skeletal malformations in 10 to 15%. So always look out for urological anomalies, get a detailed scan done, examine the spine, and get an X-ray done for the spine. If I go into the just detail, we should be knowing why does it happen. It affects because of mutation in the GAL gene, and the AMH hormone, it is not acting. So it is actually anti-Mullerian hormone which is causing these issues. So the clinical presentation, as discussed, it can be with normal secondary sexual characters and female external genitalia. The ovaries are entirely normal in this case. The serum testosterone and karyotyping may be required to differentiate between MRKH and AIS, androgen insensitivity, because in androgen insensitivity, the testosterone levels will be high. If we go for a primary goal of treatment, our goal is for the creation of a functional vagina or a neovagina. The age-old method of Frank methods of vaginal dilatation can be adopted. There are different techniques: vaginoplasty, McIndoe's procedure. This is a video, actually it shows, but I will just hurriedly go through this. We are dilating the vagina. It is by Dr. Nikhil Panse. It is not my own video, but in this they have taken a skin graft. What we have been learning, I learned in my postgraduate, was we used to take an amniotic membrane, we used to cover it with the sponge and use this cold amniotic membrane over the condom, stitch it, and use it as a mold in the vagina. And after that, we used to put a dental mold, or even candle molds can be used. So this is a broad slide which shows the differentiating features between both. Broadly, we've discussed, and major is the axillary or the pubic hair, which are present in Mullerian agenesis and may be sparse or negative androgen insensitivity. A very important gonad is ovary in Mullerian agenesis, and it is testis in androgen insensitivity syndrome. The testis in the androgen insensitivity. So this is the Davidoff's vaginoplasty, which is done laparoscopically, and the peritoneal fold is used as a to create a tract in between for the vaginal. They don't need a skin graft, not an amniotic membrane. Only the maternal peritoneum is sufficient enough. Also, there is a Vescitti vaginoplasty. It is not being much used these days. In these patients, if we need to achieve pregnancy, it can be achieved by IVF or gestational surrogacy, and in some centers, uterine transplantation. Not going into the details, but a very interesting case. This we operated around 1 month back. This patient had actually uterocervical vaginal agenesis. So this was malformed in a very small biconate uterus, and it was with vaginal agenesis and cervical agenesis, so it was removed. So complete androgen insensitivity syndrome, it has a functional testis and they are phenotypic females, but with an absent cervix and uterus because the normal AMH secretion is there. It is a receptor deformity. The receptors are defective, so the AMH is normal. It is not able to act on the receptors because of the deficiency. The vagina is short and ends blindly, derived only from the urogenital sinus. The breast development is normal because of the peripheral conversion of testosterone to estrogen. The testis may be intra-abdominal or partially descended, with more than 50% of the patients having complete androgen insensitivity having inguinal hernia. If they are incomplete androgen insensitivity, they might present with ambiguous genitalia also. So it can be detected early at the time of birth also. So the LH levels, testosterone levels are high. We need psychological counseling for these women. Creation of a functional vagina is the treatment, and also gonadectomy. But there is a catch in this. If there is a gonad with Y chromosome, it should be removed as soon as possible. But complete androgen insensitivity syndrome is the only exception to this rule, because we need the girl to grow up, and then we can actually do a delayed gonadectomy in these women once they attain the age of 16 to 18 years. However, in cases of incomplete AIS, surgery shouldn't be postponed because gonadectomy will further prevent unwanted virilization. So coming on to the second compartment, the disorders of the ovary. We have already seen that outflow tract, if it is normal, if the uterus is normal, we screen for these tests: the thyroid, prolactin, estradiol, FSH. We give the woman a progesterone challenge test. If it fails, we can also give an estrogen plus progesterone challenge, or we look at the endometrial thickness. If the thyroid is high or low, we come to a diagnosis of thyroid disorder. Similarly, for the hyperprolactinemia, if the prolactin is high, if the estrogen secretion is normal, it can be because of chronic anovulation. So she might need a progesterone in that case. These are the reference values for FSH and LH in cases of hypogonadotropic or hypogonadotropic state. However, if the estrogen is low, we need to see for the FSH. If there is high FSH, it can be because of ovarian failure, and then we need to screen the karyotype of the woman. We need to see the fragile R mutation and also the enzyme deficiencies. So the gonadal dysgenesis can be in Turner's mosaic or pure gonadal dysgenesis. There can be gonadal agenesis. There can be enzyme deficiencies and premature ovarian insufficiency because of multiple causes. Obviously, chemotherapy and radiotherapy can be in secondary amenorrhea. Gonadal dysgenesis is abnormal development of gonads, and as said, it is associated with high levels of FSH and LH. It includes Turner syndrome 45XO and is pure gonadal dysgenesis. It can present as a mosaicism also, and 5% have a Y cell line. So this is a girl, and it is clearly depicted. She has a Turner syndrome. She is short stature. She has absent sexual development. She has a webbed neck, low set ears, a posterior hairline, widely spaced nipples. There can be a short fourth metacarpal or metatarsal, increased carrying angle. However, in this case, it is not shown. If we see, there can be increased carrying angle at the cubitus valgus, lymphedema, and large cystic hygromas at birth. But most of them have normal intelligence. I've seen girls who are extremely intelligent and having Turner syndrome. These are the abnormalities which are associated with Turner syndrome: cardiac anomalies, renal anomalies, hypertension, ocular anomalies. So we need to screen for them. If I go just one slide, echocardiography should be done 5 yearly, renal ultrasound once in a lifetime, and if abnormal, it should be followed up 3 to 5 yearly. TSH 1 to 2 yearly, and more frequently depending upon the abnormality. The blood tests 2 yearly, audiometry every 10 years or more frequently depending on the abnormality. And for celiac disease, we need to screen for the antibodies once in a lifetime. In some Turner mosaics, there might be some degree of sexual development or even menses. So the confirmation of diagnosis will be clinical along with karyotyping to confirm this. The management is exogenous growth hormone, which can be started at 2 to 8 years of age till the final height is reached for 150 centimeters and can be continued for 7 years. and estrogen therapy after several years of growth hormone therapy, but not before 12 years and no later than 15 years. It can be started in a low dose and increase gradually. When vaginal bleeding first occurs or after 12 to 24 months of estrogen therapy, a progestin is added in the last 10 days of the cycle. We need to rule out Sware syndrome, which has a 46XY karyotype. It presents with primary amenorrhea. It is a form of hypergonadotropic hypogonadism. And the management, we need to do a gonadectomy in this case in 20 to 30%. Resistant ovary syndrome or the Savage syndrome has abnormal FSH receptors. The woman presents with female phenotype and has increased FSH levels. The enzyme deficiencies, there are 3 enzyme deficiencies. If we see 17 alpha hydroxylase, which lead to increase in the mineralocorticoids, the 21 hydroxylase deficiency, which increase in the level of the 17 OHP, the reason we screen for 17 OHP in these cases, and also 5 alpha reductase deficiency, which leads to the increase in the androgens. So they lead to primary amenorrhea. In 17 alpha hydroxylase, there will not be any secondary sexual characters, because if we go at the backside, there will be no estrogens in these cases. So there will be a female phenotype and hypertension and hypokalemia. In late onset 21 hydroxylase deficiency, 17 OHP is elevated, and in 5 alpha reductase deficiency, because it affects the hormone which converts testosterone to dihydrotestosterone. So at birth genitalia, the genital will be ambiguous with fusion of labioscrotal folds and urogenital opening or separate urethral or vaginal opening. The testosterone levels are normal, hence gonadotrophin levels will be normal. Disorders of the anterior pituitary. Once we have ruled out the ovarian, if there is no cause of ovarian, we need to screen further for the anterior pituitary, or if we have found an increased prolactin in the first case and the other causes are ruled out, we have to come to the diagnosis of this. So if we see, we have ruled out this, we have ruled out this, and if we go if the FSH is low or if it is normal, we have to do an MRI. Or if the woman is having a high prolactin levels, we need to do an MRI to rule out a pituitary adenoma. So we'll be discussing about this just slightly. So it can be because of the tumors or the inactivating mutation of the beta subunit. So the pituitary adenoma might present with headache, rhinorrhea, tunnel vision if it presses upon the optic chiasma, and the best method to diagnose is MRI with gadolinium contrast. The microadenomas, the serum prolactin levels are less than 200, and macroadenomas have higher levels. The treatment of choice is dopamine agonist, and we have to reassess by repeating an MRI after 3 to 6 months of treatment. Menses, ovulation, and fertility typically return when normal prolactin levels are restored. The surgical treatment, if required, will be transsphenoidal surgery, and the large macroadenomas might require a radiation therapy. Hyperprolactinemia is defined if it is more than 20. Some labs even give a range of 25, I would say. So mild is from 25 to 50. The this is from the Spirov. Moderate is 50 to 100, and severe is more than 100. So the treatment of choice is dopamine agonist. We can give a cabergoline 0.25 milligrams starting in a low dose of twice weekly, or bromocriptine 1.25 milligram daily bedtime. So to minimize the side effects, treatment with either drug should begin with a low dose and increase gradually, guided by serial prolactin levels obtained at approximately monthly intervals. The prolactin levels typically decrease within 2 to 3 weeks after the treatment begins. So if we have ruled out the anterior pituitary, actually the disorders of hypothalamus or the central nervous system are by exclusion, or sometimes the girl might give a history of excessive exercise or stress eating or bulimia nervosa. So we have to go into the detail of the history. There can be a physiological delay also. These girls present with short stature, delayed secondary sexual characters, and delayed epiphyseal maturation. And the treatment is watchful expectancy. We need to be watchful, but we have to call her for a follow-up. Then the congenital hypogonadotropic hypogonadism. It is autosomal dominant, and it can be either with normal olfaction or with anosmia in cases of Kallmann syndrome. These all are the different syndromes. We need to have a multidisciplinary approach to manage these cases. The child might present with anosmia, skeletal abnormalities, lack of secondary sexual characters, primary amenorrhea in girls are discussed, and rarely some females can have thelarchy and menarche and symptoms appear thereafter. The management is induction of puberty and maintenance of sexual maturation and depends on the patient's age. And we might have to give estradiol or progesterone in the last 10 days to prevent endometrial hyperplasia. So the eating disorders which are very commonly seen are anorexia nervosa. And a girl, she refuses to maintain body weight and they are so adamant, they have a fear of gaining weight. They are fear of distorted body image with undue importance on weight or shape. In postmenarchal females, they present with amenorrhea. And we need to have a counselor, psychologist along with us and a pediatric pediatrician also if possible, so that we can give a combined multidisciplinary approach to the girl. Someone might present with bulimia nervosa who has binge eating episodes, and on the same side, they also go in for self-induced vomiting or misuse of laxatives. So binging and purging behavior should be sought out for. So the management includes, as said, requires nutrition, medical monitoring, and cognitive behavioral therapy, antidepressants if at all required as a last resort. But we need to understand the psyche of the woman. Someone who does an excessive exercise or someone who is an athlete might have hormonal imbalance and might be having primary amenorrhea. So what is required is a lifestyle modification, low dose oral contraceptive pills, or maybe. So to summarize, as we said, if we have to investigate, we discussed if the pelvic ultrasound, the uterus is present, we ruled out the outflow tract obstruction. If the uterus is absent, we need to understand the karyotyping after the history and examination. If it is a normal anatomy, we rule out all the hormonal changes. Suppose there are absent secondary sexual characters, we look out for the height of the woman. If it is normal, check the FSH and LH. If they are low normal, there can be a physiological delay, the Kallman syndrome, or it can be cranial CT MRI to rule out a CNS lesion. If the FSH levels are high, we have to rule out the karyotype 46XX in cases of primary ovarian failure, renal dysgenesis, or resistant ovary 46XY in gonadal agenesis. If a girl is short, we again look at the hormones. If they are low, it can be because of the hypothalamic pituitary dysfunction. If they are high, we need to look out for the karyotype and gonadal dysgenesis needs to be ruled out. So my take-home message will be, logically, the recommended evaluation from amenorrhea is designed to separate the reproductive physiology and function into distinct structural components: the genital outflow tract and uterus, the ovary, the pituitary, and the hypothalamus, and to test the functional integrity of each, beginning at the lowest level and progressing systematically to the higher levels of the system until the cause is determined. A systematic, methodical approach helps arrive at a clear diagnosis, which helps in deciding the further course of management.